I have like we've just been saying, I have the greatest of respect for Dr. Soneji. He's been a teacher in more ways than one, and he has been a teacher for so many people who have benefited from his expertise, not just in cardiology, but overall in general medicine. So yes, it's a pleasure at any stage to be associated with the platform with Dr. Soneji. I'm about to start my screen sharing.
Please go ahead. Yes.
Let me just give you the sharing rights.
Yes, please.
Yeah, please go ahead.
Let it mute everybody.
Yeah. So, Omji, you'll have to unmute yourself.
Yeah, okay. Yeah. Okay. Can you hear me now?
Yes, we can hear you.
Yeah, okay, fine. So let's get started. I think without any further ado, let's get started. Uh, COVID, as I'm sure you will agree, has now become something like reading the tea leaves. You know, in the ancient Chinese, how they were, experts in some way or the other, where they could read tea leaves and tell you what is happening and what is likely to happen. It's pretty much coming to that stage for COVID ourselves, and forget about any one particular segment. The entire scientific community is also pretty much groping in the dark. It's like the elephant in the room, with four blindfolded men. Everybody has a different perception of what can be happening, and so COVID right now is a state of learning for everybody, including me. But I'm going to share a few things about what we know with certainty and what we think is likely to happen. Okay, so at this time, we've now come to about 18 months of COVID, starting from say February, March of last year. We have already had two waves in India, the first wave and the second wave. The second wave, of course, was more grievous than the first wave. And that in the second wave is where we have learned most of the lessons that were really harsh. We learned that the infrastructure that we have cannot manage the total number of patients who need help, whether it's a public hospital space or the private hospital space, and that a lot of things that we thought could not have been done at home. We looked at having home care for a number of patients. We also learned that there was a role for large domes of 1,000 beds each or 2,000 beds each, where people who could not have lived in their homes, but also did not require to go to hospitals. So those were things about management of COVID that we learned as time went on. And with the amount of literature that was coming our way, we learned everything, that some things that we knew at the beginning of the COVID were no longer true, no longer relevant, and that there were other things that we thought which were insignificant have taken a role in center stage. There is an anticipated third wave, as I'm sure you would have gathered and agreed. The third wave is meant to be, well, at some stage it is meant to be starting at either the end of September or the early October part. And whether it is going to be involving children or sparing children, or involving adults or sparing adults, I have to say at this time, all of that is conjecture and speculation. Okay, in spite of the fact, there were a number of people who have done very well in predicting, uh, models of timelines and timeframes of infectious diseases. So let me assure you that with COVID, each one of them have turned out to be false, right? So I don't think that anybody knows. If there is somebody, let them please put up their hands so that we can learn from them as well. But at this time, I don't think that there is any one person who can say, yeah, I know where COVID is heading, what the third wave is going to be like, and when it is going to end. So right now it is, as the Americans would famously say, watch the space. And that's what we are doing. We are watching that space. Okay, so a great deal has been said about the strains of COVID-19, right? The alpha strain that started off in the United Kingdom, that was in the month of November or December of last year. But I'll tell you the funny part about the alpha strain. By the time the alpha strain was described and acknowledged that the alpha strains, exist amongst us, it had already been described in a place called Kent in the United Kingdom. And Kent was already reporting that there is a variant of the strains of COVID-19 and that this variant is, we should name it. And so for a lack of a better term, it was named alpha. But this was described in September of last year. By the time it came to the shores of India or other parts of the world, it had already been within the population of people living amongst us. And so this is one of the difficulties that we are facing or we are going to be continuing to face. We are not able to close down borders completely. Now, there are a number of reasons. There are commercial reasons, there are geopolitical reasons, there are medical reasons as well. But you cannot shut down a city or a country simply because we say that, look, it's not a good idea for so much of movement, because we have seen that these trains become important only in contagious situations where there is no physical distancing, there are no masks. An airport like, say, Heathrow sees millions of people every day who are going and coming in and going out of the airport and traveling. So I'm only giving you an example as to why it is difficult for a public health authority to say we are not able to overcome. We're not able to overcome pretty much what the US is going through right now, in spite of what they are doing, and they are doing a fantastic job in trying to contain the the story in a number of cities, in a number of states, Dallas and parts of Michigan, parts of University of Alabama, Birmingham. All of these states have actually spoken to the federal government to say there are no pediatric ICU beds available. So they are having to send the kids who need to be hospitalized to the nearby state, not the nearby city or the nearby hospital, to the nearby state, because they are not having the pressure of so many beds. So again, I'm only sharing with you that it is no longer a matter of simply saying, let us examine COVID, let us treat COVID, and let us contain COVID, because it is actually at this time, it is out of pretty much everybody's hands. So the alpha strain, as I was saying earlier, with the UK strains as to where it was, there were other strains, the beta and the gamma, that did not have the same kind of significance as the alpha strain. And now we are in the middle of the delta and the delta plus strain. So the delta strain, of course, is the one that is causing all the confusion, chaos, the smoke screen of what we are dealing with. Is there a problem with delta? Yes, definitely there is. How bad is delta? Well, it has the potential to be worse. How bad is delta worse? Again, the same thing. It has the potential to be even worse than what it is right now. What is the good thing about delta? We're not seeing so many people dying. Okay, I've actually, in the second wave, actually, from the first wave to the second wave, I've lost count of the number of prayer meetings I was invited or asked to attend, because I knew those people. So many people that I know have succumbed, either gradually or suddenly or in hospital or at home, that I've lost track of how many people have succumbed in a given family. And just about everybody that I know, every other house has had one fatality, one death. And that has been the story of COVID so far. Fortunately, with Delta, we are not seeing the same numbers as we saw in the second wave, but that is Delta up until now. And what's going to happen from here? Is it going to stay at Delta? Well, I don't think so. You see, one of the big troubles is that this virus, because of its inherent nature, it's a sly virus. Okay, it's a cunning virus. It's a virus that has been described in in reptiles. Okay, the COVID virus before the COVID-19, it exists in serpents, in alligators, crocodiles, lizards. So the inherent DNA of the virus, the inherent fingerprint of the virus, is one that learns to survive within these animals, right? So some part of that is going to be translated into its existence amongst human beings, which is COVID-19, and that this is where it is going to keep changing its track. So What we now do, we keep a track of how many times the fingerprint, if there are 100 elements to the fingerprint, how many times has the fingerprint changed and when has it changed? So every 11 days, there is one slight change, which is a mutation, which is what was described as a mutation. And this is going to keep changing every 11 days. Up until now, there have been more than 17,000 variations that have been described to the COVID-19 virus. I'm only sharing with you these figures to give you an idea as to how truly, you know, cunning this virus is amongst us as well. So we are fortunate right now that Delta is not having the same fatalities. But what happens if there is a Theta variant? What happens if there is a Lambda variant? What happens if there is an Epsilon? And what are we going to do after that? Are we going to Alpha 1, Alpha 2, Alpha 3? We don't know any of these things. We don't have answers to any of these things. And so it's important to, again, like I was saying earlier, like the Americans famously say, watch this space. That's what we are going to be doing, keeping an eye. And hopefully, if it does not go beyond Delta, then hopefully there is going to be no further damage to what we are already seeing. And so this is a term that you would have heard very, very frequently. Sequencing, the genome sequencing. And what is it that we are talking about when you say, what is the genomic sequencing? You have a patient who has a throat swab. A throat swab cultures the virus and finds that there is the virus. The virus then goes into a laboratory, into a machine, which is the sequencer. And that looks at the genome, which is pretty much the fingerprint. And that is marked by very clear signature changes. These are the basic fingerprints of the virus. When the virus goes through a mutation, like I was saying a little while ago, this mutation is simply that, as there is you, there is also a cousin or a twin that looks like you, except that this twin speaks a little differently or has a different, hand, it is left-handed as compared to you who's right-handed. Those are the changes that will be identified in a sequencer, which looks at the basic fingerprinting of the virus. This actually identifies in the community, which is the prevalent strain, which is sitting in the community right now. And that is what tells you whether you're dealing with, an alpha or a beta or a delta or whatever else is going to be coming your way. This is critical as a public health tool. It's also critical in other spaces in diagnosis and treatment of COVID. But as a public health tool, it is pretty much the most important thing. Now, why is this important to share with you? India does about 0.7 to 0.9%, less than 1% of the total number of positive viral samples that go for genomic sequencing. That, to my mind, is far too little for you to be equipped with the medical information that you're seeking to make sure that the next set of patients who come with COVID are going to be the best served, right? I must admit here that sequencing is a very recent tool. It is something, when I started speaking about sequencing, that was only in the month of, I think it was in the month of May or June of last year. Between then and now, we've made rapid strides, but that's not enough. It's not enough to be saying, yeah, we made rapid strides. We need to do more. We need to sequence more. We need to have more machines, more samples. We need to have a lethargy to be shaken off. We've got probably one of the best set of machinery with National Institute of Virology, and now in one public hospital in Mumbai. But even there, the total number of samples that have come since the lab was opened, there have been only about 70 or 80 or maybe 90 samples as of today. It's nowhere close to the sampling that we are hoping to get. So there is something to be said about the involvement of the public. There is something to be said about the education of the layperson and the amount of support that public health officials will get from people coming forward and saying, here, we've got somebody who's positive in the city in where you're living, and that here, please take the sample, and I would like that we should have genomic sequencing on this sample. So a long way to go in finding out where we stand, but it's a start. We've started somewhere, and that's all that matters. As the famous Chinese monks would say, a journey of 1,000 miles starts with but a single step. This is where we have taken the first single step, and we are looking at covering the 1,000 miles as soon as possible, as soon as we can. I'm going to say a few quick words about diagnostics, right? And I'll tell you why, because Dr. Soneji also said to me that there is a population which is frequent travelers. You travel in the country, you travel out of the country. The big question is, what diagnosis is safe for me to be going into an airplane? And what diagnosis is safe for me to allow somebody to come and sit next to me? This is a question I get asked very, very commonly, right? So I will talk to you about seroprevalence. What is the meaning of R0, RO, and what is a positivity rate? Right? Seroprevalence and positivity are actually two sides of the same coin, right? A seroprevalence only tells you how many people have actually had exposure to the virus. Do remember that out of 100 people who have exposure to the virus, about 85 to 90% will recover spontaneously. They won't even need in fact, they won't even know that they've got the infection because the symptoms are identical to the influenza. So you may have a couple of sneezes, a runny nose, a little bit of a sore throat, a little bit of headache, backache, body ache, and that's about it. So you unless you look for it, you may not even know that you've got COVID or you're somebody that you know has got COVID, and that this will stay in your patient system as something which is there that tells you that you've been exposed to COVID. That is one part of the seroprevalence. The positivity rate also tells you in your community, if you've tested, say, 5,000 samples in a laboratory, you are finding out that the total number of people who are positive in those 5,000 samples is this figure. And that's what it means, that you're positive for the virus either currently or you've been exposed in the past. The R0 is simply a number that we look at in finding out what is the doubling rate. So if you say the R0 is say 1.5, right? So 1.5 of say 100 samples, the R0, that means the doubling rate will be 1.5 into 2, which is the doubling sample. That becomes 3. But then the R0 for 3 becomes 6. So the R0 in a number keeps climbing, and that is what is going to be a major part of deciding how many people are going to be infected in a community. These figures are very important in public health, especially in those centers in the interiors of a state which do not have the same kind of facility as say a city like Mumbai or wherever you're living. The rapid antigen test is an immediate test. You will do the swab and a test will be done, and that will give you the result inside 2 hours time. Unfortunately, the sensitivity of the rapid antigen is only about 35%. So a positive rapid antigen test is helpful in say a hospital or a place which has done the test, your patient has tested positive. You do the RT-PCR after that to confirm, because the RT-PCR is the gold standard of the test, right? So that is where the rapid antigen test comes, and that's where the RT-PCR comes. The gene expert is actually the most sensitive. The problem with that is it's not available in every center, and it is time consuming. It might take anywhere from about 12 hours to about 3 days time, depending upon how well your laboratory is geared to take on these tests. I'm sharing with you again these parts of diagnostics because a lot of people will come up and say, look, I've done a rapid antigen test, I'm negative, and I don't need to be tested further. So that does not apply. That's not something that you can translate. You need to be speaking to your doctor as to what it means, and you need to be aware as to whether you can be traveling or moving along freely in a particular situation. I'm going to say a few quick words about, this is actually a very good study that came out of Oxford. Without going into too much details, the spreading shows, the shaded area shows about a 95% confidence interval for the period of the study. Essentially, I'm trying to share with you here that those people who have been vaccinated and those people who have not been vaccinated, there is going to be a difference in the antibody levels in those patients. There's going to be a difference, just to be expected, but that is there. It can't be disregarded, and it can't be wished away. Right here again, it's another extrapolation of an unvaccinated, whereas a vaccinated. Now here is a vaccine breakthrough. The one big question that I'm sure comes to you as well is, look, I've already had COVID. How did I get COVID again? All right, these are breakthroughs. They come as a result of a breakthrough infection, which is defined as a second or a milder infection of the same infection, all right, the same bug. In this case, it is the COVID-19 bug. So you can get a breakthrough. You can get a breakthrough after a vaccine, but it is going to be milder and less aggressive and should not give you the same set of problems as you would have had when the first time you got COVID. So it's a good slide. It's a simple slide. It does not have a lot of information. It's simply to let you know that breakthrough infections exist. They exist in a very small set of populations, but they are there. They are not going to be wished away, and we should be able to acknowledge that they are going to be around. All right, I'm coming to the last part of what I'm speaking, and I'll stop here after this part. Vaccines, the big vaccine question is, what am I going to take now? Am I safe here? What about the vaccines that are going to be available in India? Pardon me. So right now, with the two vaccines up until just about a few weeks ago, they were the two vaccines, the Covishield and the Covaxin in India. Now there are going to be more vaccines. There's already been approval for the Sputnik. There's also going to be the Pfizer vaccine. I think the Pfizer may not come to India because they've got a difficulty with the indemnity. They don't want to sign the indemnity, which is pretty much to say that we'll take your money if you want to take the Pfizer vaccine, but if you get a complication, we're not going to be responsible. Which is laughable, but that's where things stand with Pfizer at least. So there are going to be other vaccines that are going to be available. There's going to be the Moderna. There's going to be the Johnson & Johnson. There will be other vaccine candidates. There are candidates that are going through various portals, like the messenger RNA, the first one that is on the slide. The messenger RNA is a very good, it's a new technology in this set of infections. We've never used a messenger RNA current technology, and right now it appears to be giving you very good results. The RNA is part of your system, part of your cell, that makes sure that the information coming its way is sent to, pardon me, is sent to the rest of your body in a way that will protect you, right? There are other vaccines. Sorry. There are other vaccines which are mounted on a virus called the adenovirus. These are killed viruses that will also take the vaccine within itself and translate it into information that will go into the rest of the patient's body. The third is the DNA vaccines that have come now. They're very recent. There are also other vaccines in the pipeline. And there is, of course, the big question of whether you need a booster dose. So to my mind, yes, we are going to need a booster dose. There is a very recent study, in fact, a study that came out only about 2 days ago, that says that the effect of the vaccine may not be lasting for any more than 6 months' time. That means you may have antibodies once you take your booster dose, you do your antibody test, you find out the antibody figure is very good. But if you do it again at the end of 6 months' time, you find that you may not have had the antibodies there at all. There is a second category of people who will not mount a response. That's a small category. You get the vaccine, but you don't have any antibodies in your system. That usually means that you're going to need a booster dose of the vaccine, and that may also require other vaccines. You may be having a different response. And see, I'm sharing these things again with you because he says none of these is based on either COVID-19 or a drug that's treating you or a vaccine that you've given. It is based on how your immune response behaves after you've had that exposure. So, we have a bad joke in teaching infectious diseases that it's not the bug that's going to cause you harm or kill somebody. It's actually your own response that is going to determine how well you recover from that bug. Because if you have two people having the same infection at the same time who are matched for age and comorbidities and all the other things, both the people will have two different responses. So that's because your immune system behaves differently as compared to somebody else. So no two individuals are identical or alike. Is there going to be any need for a booster dose? Yes, I'm quite sure. What else is likely to be happening? Well, like we have the influenza vaccine at this time, we're probably going to find that a recombinant vaccine with more than one route of the COVID-19 vaccine will be combined into one vaccine and a shot will be given maybe once a year. That's where it is probably heading. That's where it's probably heading. I say this because a lot of people who are wanting to be traveling will need to make that revision in their plans. This is probably in the very foreseeable future, in the next maybe 6 months to a year's time, maybe even lesser than that, because that's the only other protection that you're going to get insofar as traveling is concerned or your own immunity is concerned. So vaccines are going to be major. They are going to be a major part of our lives, and that will continue so long as COVID continues, or even after that. I should also give you the bit of information that the WHO says that COVID-19 may become endemic to India, which means that we are not going to be able to get rid of it. That's the WHO's point of view. I'm not saying I endorse it. It is possible, but to my mind, it is too early to say. It's too early to say. It's quite possible, but we'll know more in the next maybe 2 or 3 years' time, maybe 5 years' time. I'm going to stop here. I think that this is about the amount of information that should be shared with, Dr. Soniji said that all of you are very enlightened and very well-read people. So I've kept it, I've tried to keep it at least as simple as possible. Uh, and that I hope that this information is of use to you. I would like to thank all of you for a very patient hearing. I'd also like to thank Dr. Soniji for giving this opportunity. Thank you, sir. And if you do have any questions, I'll be happy to answer.
Yeah, thank you, Doctor. It's been a pleasure listening to you and understanding what really is going on.
Doctor, can you stop the screen sharing?
Yeah, sure.
Doctor, I have a question.
Prashant,
Yeah,
sorry, can I just take this ahead a little bit and then you can ask if you don't mind?
yeah, surely.
Thanks. Yes, Doctor, thank you so much for educating us and taking us through this, whole event that we've been through that has transformed our lives. I have a few simple questions. Of course, a lot of them have been answered by you, but just reaching out to some of my Seacoasters, this is what I've been told to ask you. Does COVID have long-term side effects? I mean, long-term effects. I mean, of course, you said that everyone is learning today, but do you think this could impact people with other ailments in the future?
So look, excellent. Both the questions are super. You have two parts to your question. First is this going to be having long-term consequences? Yes, it will. It will definitely have long-term consequences. There are various systems in your body. Some of them are going to be affected more, some less. The one system that is definitely going to be affected is your blood circulation, your connective, your blood, pretty much, which is now treated as a separate organ. All right, when you say that somebody has a report in his blood test that's abnormal, that's considered to be one organ dysfunction. So yes, we are already seeing people who were infected this time last year are having clots in their body. They're having clots in their head, in their lungs, in their gut, in their legs, everywhere. And that is there. Now, how long it is going to last, we don't know, but we're quite certain it's going to be around here for a substantial period of time. That is one. The second thing is, will COVID affect other illnesses? Yes, that is also likely. That's also happening. We are seeing that some more in some neurological conditions, but also gut conditions. Anything that is going to impact on your immune system in a way that your immune system is required to be, solid and static in its response is probably going to be affected by COVID. So unfortunately, I have to say, uh, even if this is not entirely correct at this time, unfortunately, the evidence does point that it's going to be impacting other organs in your patient system. Yes.
Understood, Doctor. Mr. Cyrus Poonawalla announced recently that he's taken the third dose. Now, imagine a situation in India where, a lot of them have actually not taken the first dose. Tomorrow, if I need to take my third dose, I think it's going to be a long haul, right, Doctor? Which means infections would continue to, move up and up. And that's when I'll get my third dose, right?
Yeah, so that disparity is going to stay in a country like India. If it's there in in other developed nations, it's going to stay. It's definitely going to be around in India. Because look, you and I are sitting in Mumbai and talking from Rich Candy and Malabar Hill. But there are those people who are living in the backwaters of Kerala who probably have, they need to walk to their primary health center, which is the most basic structure of healthcare. But they need to walk for 3 and 5 kilometers to get there. The doctor there has probably the most basic information at his disposal. And so giving him the access to first dose, second dose, third dose of the vaccine for the entire village, that's going to take some time. I don't see it happening immediately. And, what you're asking is very relevant in how it's going to play out, and that census figures may not be entirely reflective of the kind of exercise that the government of India has embarked upon. It is such a humongous exercise that to get it to complete 80% of it, that also is going to take such a lot of physical resources of government machinery, public health, patient participation. Okay, I can tell you, at the peak of the H1N1 crisis, there is a complication that happens when you take the influenza vaccine. It happens in 1 in a million people. Okay, that's how rare it is. And so when we would talk to hospital staff, healthcare workers, to take the vaccine, to go to them and counsel them and tell them. So the nurse would say, "But sir, there is a complication of this nature that happens once in a million people." You'd say yes, and so they would ask you, "How do you know I'm not that 1 in a million?" Right? So vaccine hesitancy is a reality. It's not something that will just go away because we say that we are ready to get rid of vaccine hesitancy. But it's something that we have, now that we've embarked upon it, we'll have to find a way to get around it. So
Sure.
the first dose and the third dose, yeah, the question you're asking is very real and it's very much here.
Understood, doctor. Typically, vaccines take a long time to actually come to market. Here we've had vaccines come in at super fast pace with great efficacy figures being shown. Do you think the vaccine that I've taken could cause me some harm in the future, or are there any potential issues that I could face by getting vaccinated every 6 months or 9 months?
I think whoever is, if it's you who's framing these questions, you've decided to ask only all the controversial questions to a non-controversial man. Yes. I have to advise Dr. Sonaji, sir, please, next time we should frame the questions together. That way.
Oh God.
Hopefully that will not happen. No harm should come to any patient, anybody who takes the vaccines. It is true. You see, if you look at the vaccines that have come up in the last 10 years' time, whether it is the Zika or the Ebola or the H1N1, each of these vaccines take anywhere from about 5 to 10 years, and in some instances it takes about 20 years. All right, so it's true that the process of vaccination has been compressed and fast-tracked, but it is also true that when you do that, you're going to have to make some adjustments, and that all the numbers that we are seeing are basically very good on paper. See, when you take a flu shot, your doctor does not ask you to come back in 1 month and tell him how are you feeling in a month's time. You tend to ask that question 1 year after you have finished taking your flu shot. So you will then tell your doctor, look, in the year before this, I had 20 flu infections in a whole year. In the year after I've taken the flu shot, I've had 3 or 4 or 5 infections. So that is the time frame it is required to assess whether the shot is working for you or not. So, it is too early, it is too premature. We don't, like I said at the beginning, we don't understand COVID completely. So where is the question of understanding a vaccine completely? I think that all the gray areas are so many. There are so many gray areas that the only thing we can do is to, when the evidence comes, which is solid, we learn from that evidence. Other than that, the rest of it is only paper. Yes, we don't read papers, we don't read numbers, we don't read scans, we treat patients. We should stick to what we are good at, what we do best, and hope that all the good practices of medicine will see everybody through, everybody.
Right, doctor. Thank you so much for that. Doc, also another question. We've seen Israel and the US vaccinating at an amazing pace, and yet they're back. The cows have come home. 236,000 infections in the US, or 256,000 infections in the US. What could they have done differently? I mean, yes, COVID appropriate behavior is a very cliched term, and I understand that. Could they have done something more scientific before opening up, their economies the way they did?
I think US for sure. US for sure. US because their entire population has not been vaccinated. The total number of people vaccinated in the US is about, I think, 194 million, or less than 200 million. That leaves actually it leaves about 140 million, about 40%,
Yeah,
who have not been vaccinated. That's a huge number.
right.
While it is true that the number of people who've been vaccinated in the US is 190 million, it's also true that 140 million is not a number to be disregarded. That's a significant number.
Hmm.
Israel, on the other hand, they did a very good job. They got about 95% of their population vaccinated, and they tried to ensure that a lot of the population, the high risk groups, got their third dose, which was a messenger RNA vaccine. Right after that, when they found the antibody levels in these people, they were very good. I should have shared that slide with you. The total amount of antibody levels in Israeli populations after the third dose is very good. It's very encouraging. But as it turns out, Israeli populations and the antibody levels existing in those patients may not have been as reassuring as the numbers say. Right? And that the infections that the Israelis are getting, I'd like to know more about the genomic sequencing before I can comment. That is it going to be as good or as bad as Delta or Delta Plus, or is it a new variant? So I'll tell you, the biggest burden right now in the whole world, in the whole planet, is coming out of Peru. Peru has the worst diverse mix of infections. And Peru is not able to keep its borders, sealed. There's a huge amount of movement from Peru and other countries of South America. So, I think that this is a work in progress. I don't think we've seen the last of COVID. And again, like I said, are you going to stop a person from these places, from Central South America, to come to US or Central India or anywhere else in the world? So since you're not going to stop that, I don't think we can assume that this is going to be the extent of how every patient is going to behave once he or she has got the vaccine.
Thanks, Doc. And one final question from my side, Doc. How do you think, in your experience over the past 18 months, how has COVID, interacted with children? I mean, what is the extent, or have you seen some major issues there?
So no, in the first and the second wave, I didn't see a lot of children. In fact, I virtually saw no children. I didn't see. I can't remember the last time I saw a child in ICU who went through complications that were life-threatening. That was in the second wave.
Okay.
In the recent past, in the last about maybe a month, maybe a couple of months, there have been a number of children who have been admitted with a condition called the Kawasaki Syndrome, which involves a number of organs, but most especially the heart. That's happening now. That's happened now in the last couple of months' time. I'm not a pediatrician, so I don't get involved, but those patients whose families I know, they talk to me about what's happening with somebody who's a child in their family. And that's how I know. So it is something that is happening now. There's no particular pattern of why it's happening, where it's happening, but it is happening in children who get sick and who need a lot of assistance in ICUs with this kind of sickness.
Wow. Okay. Doc, I'm done with my questions. Prashant, sorry I cut you off in the beginning. You can please go
No
ahead and
problem.
ask.
Yeah. Good evening, doctor.
Good evening.
Yeah, this on hindsight, do you think remdesivir and tocilizumab and flavipiravir was the right line of treatment, or was it a big game by the pharma companies? And what is the line of treatment now compared to what was there in the past? Because
Okay.
everybody was running helter-skelter to get that injection and remdesivir, and so on hindsight, was that a right line of treatment at that given stage?
I think you've answered your question yourself, Mr. Prashant. I think the answer to your question is in the question itself. See, remdesivir and favipiravir, neither of them have shown any survival advantage. Okay, so what you're going to do, if your virus is going to be shedding in your system for 7 days time, you give a patient remdesivir, the total amount of shedding will fall to 6 days time. That does not mean it's going to get you rid of the virus, right? Favipiravir in itself, with the trials that came out subsequently, has been shown to be of no effect, really of no effect. The tocilizumab, yes, there is some evidence, but tocilizumab is not a treatment for the virus. It is a treatment for the inflammation that comes after the virus has left your system. Yeah, okay. The same applies to itolizumab, same applies to baricitinib, same applies to Regeneron, right? All these elements, all these 4 compounds that I just mentioned are compounds for when your immune system is not able to control the total amount of inflammation. That's when you are going to get the features of inflammation. And for that situation, you are going to require these agents, whether you use tocilizumab or itolizumab or any of the other agents. So it is something that you ought to be keeping in mind. There is evidence that biological agents and immunomodulators have shown to be of benefit, of survival benefit. If you started at the right time in your patient, most patients will get up and go home. Just today, I've discharged somebody from Jaslok Hospital, who is a very close associate of a national leader from the BJP. And the entire state machinery of the BJP was giving me a call because he turned up to hospital virtually half dead. And so I started 2 agents, 2 of the agents that I've just mentioned, and he recovered. Quite fortunately, God is kind, he recovered, he's gone home today. So it works, it definitely works, but you've got to pick the right patient and you've got to time it correctly. That's very
So the line of treatment is the same, doctor, after so many months, or is it there is some change in the line of treatment?
No, see, there are a number of agents that we discussed and we have used in the past, including things like hydroxychloroquine, including things like doxycycline, including other agents, number of agents. None of them have been shown to be of any benefit in survival advantage or to stop the virus from being shed. The only things that have showed an advantage is, like I just mentioned, those agents that modified the response of the immune system. But again, that's not a blanket recommendation. It has to be picked correctly for the patient who's likely to benefit the most.
Om,
Yes.
can I ask you a question?
Yes, sir.
Okay, now I was told that when you do antibody testing, you should be testing neutralizing antibody. That is the antibody that prevents you from getting into trouble and multiplication of the virus. Now, unfortunately, that is being done only by large laboratory. Other laboratories are just doing plain antibodies. Is it okay to do any plain antibody, or do you do neutralizing antibody?
So that's a super question, sir. See, when you get antibodies, there has to be a percentage of your antibodies which are going to be neutralizing antibodies. That is going to be 20%. It's the IgG part of your blood test that is tested. And that must be at least 20% for it to offer you protection. If it is less than 20%, then it is not enough. It's not enough. So when you say antibodies to the spike protein of the virus, that is what is going to be most protective. But as you've already rightly pointed out, this number of antibodies will start dwindling over a period of time. And that is a couple of months, maybe 3 months, 6 months. The most recent study of the UK says that the vaccine is not protective for any more than 6 months and that the antibodies will start dwindling. So how are we going to counter that? Are you going to require 2 booster doses in a year? Maybe. Is that going to be the next approach? Are you going to be requiring, if you combine the vaccine with other vaccines, is that going to be a better booster for you? We don't know. We are speculating. We are looking laterally. We are trying to extrapolate as to what could be the best advantage. But that's what we do as people who are in the scientific part of treatment. That's what we do. So I don't think we know the answer to that as yet, sir. But I do feel that yes, we will need to devise a way where the total amount of antibodies will be longer in your system, and that your booster dose may be, I mean, even taking it once a year is going to be a little bit tedious for a lot of people. But if it comes to once a year, I think we should be happy.
What about T cell immunity, which we cannot measure? We only measure the B cell and we do the antibodies. I'm told there's something like a T cell immunity which really helps in preventing the spread or multiplication of the virus? What is your opinion on that?
So, sir, T cell is the, as we say in Hindi,
I must. Yeah.
the T cell is the Raj Yog, all right? T cell has a Raj Yog in that what the T cell is going to do, it's capable of a number of actions, but it is going to do nothing until the B cell presents it with the antigen presenting APC. Okay, so until the APC comes, the T cell is only lounging. It is relaxing, enjoying its pina colada, and just doing nothing there. Once the B cell presents it with the antigen presenting cell, that's the time the T cell gets into action, and that's when it is capable of doing so much good to the system. Unfortunately, you're right. What we tend to measure is the CD4 count. I'm not going to go into too much detail.
Yeah, okay.
We tend to measure only the CD4 count. We don't tend to measure the precursor of the CD4, that is CD45. So the test that we do to measure the T cell is only an indirect reflection of what your patient is going to go through. What we need is the CD45. Unfortunately, we don't do that. So the understanding of the immune system and immunology is a separate science altogether. It is something, it's one thing to ask for the test because the lab says so, or you've read it somewhere. Quite another to be able to interpret it to the best use of your patient. So that would be, if you'd like at some stage, I'll try and simplify it further and talk about it at another time. But at this time, for the August gathering that is there, I think this should suffice, sir.
Thank you.
Doc, I have a simple question. When can I have my pina colada with my colleagues?
Right now.
I
Right
can,
now.
right?
Right now,
Okay.
you can start it right now. So long as you're having with your colleagues, that should be fine.
Okay. Guys, anyone has any questions, please take this opportunity to, ask Dr. Om.
Doctor,
I have a question, Kunal.
Yes, Dr. Aban, please go ahead.
Yeah, good evening, sir. I'm Dr. Aban. I would just like a simple bit of advice to our club. Over the last 1.5 years, we've been having speaker meetings on Zoom, but we have been doing all the philanthropic activities that is associated with a Rotary Club. All our projects have been going on. When do you think it would be safe to meet physically? We are a group of, say, 68 members, and since we've had a hiatus of meetings for the last 1.5 years, there could be a very large attendance in the early meetings that we may have. And the meetings would involve, after the speaker finishes, drinks and dinner. How safe would that be, and how soon should that be? Keeping in mind that most of us are senior citizens.
And
Comorbidities.
vaccinated.
So that's again a very important question. How soon can you start? So I'll tell you, as I'm sure you're aware as well, ma'am, that the virus is now airborne, right? It is actually the particle matters are in the atmosphere. They're so small that there is no way you're going to be able to contain it. So in that situation, when it is airborne, it can come even if you're living in an air bubble, right? Even in places, there are institutions where they test everybody coming into the campus. In spite of that, they've had 3 outbreaks.
Yes.
Okay? They've had 3 outbreaks. So I don't know if there is any situation where you can prevent the virus from coming to you. The only 2 things that we have shown, 3, to be able to at least contain the spread of the virus is that you are masking, you're keeping your social distancing, and you're washing your hands. If you are able to keep that in mind with your meetings, if there's enough space between 2 people, there is enough social distancing. People are sitting at least a distance of 1.5, 2 meters ideally, but even less than that.
1.5 meters.
But what about eating and drinking? You'll have to remove your mask for that. Wouldn't that be a bit dangerous?
See, you're like I'm saying, the virus is already airborne. If you are going to have a drink, by all means, I don't think you should. How many things are you going to cut out of your life, and for how long? See, you need to be able
That
to.
is an important question.
Yeah, so you'll need to find a balance about what you're doing with your responsibility. I don't think that there is any body, either the WHO or the UN or the state government, that can advise you on how to look after yourself. That is something that only you will be able to know. And that's the person who can look after yourself the best is you, is you. Nobody else can tell you, not your doctor, not your friends. You are the person who will be able to look after yourself the best way. So I think that it is time to get on with what can be done socially responsibly, but be aware that yes, it's possible to get the infection, and that if you've taken your vaccine, then by all means start your physical activity of mingling and talking to people, but with all the responsibility that is required. Yeah.
Thank you.
Doctor, what is the role of steroids in the treatment?
Oh, those were pulmonary involvement.
So in the initial part of the infection, up to the 7th day, steroids have been shown to be beneficial in the shedding of the virus. Even though, as a paradox, in the presence of an infection, you're advised not to start steroids. But in this situation, because the shedding of the virus can be in such large numbers in the initial 7 days time, steroids in a small dose under supervision is indicated that that should not be a problem, except that we've also seen that in very big uses of steroids, in high doses of steroids, there is a predilection to fungal infections, especially mucormycosis. So that's a double-edged sword. You've got to find the balance. You've got to see what works for your patient. You've got to do all those responsible things. But otherwise, steroids in the initial part, the first 7 days time, they are shown to work, and they are shown to work with a lot of benefit to the patient.
I would agree with you, doctor, because I went through COVID myself, and I had a lung infection, which was 11 on the scale, and I was advised for 5 days only 8 milligrams to be cut down. 3 days 8 milligrams and 3 days 6 milligrams, and it worked wonders. It actually took away the complete infection.
Yeah.
I just wanted to share that with you.
Yeah,
That was the only thing that was troubling me. I was double vaccinated, and I went through the 14-day process, except for this chest being full of mucus, which actually was removed by mucolite, that medicine that you have, sustained release. And I must have thrown away 150 tissues, spitting out the mucus. And on the end of 5 days, I had no problem with my chest.
Yeah, so that's expected.
I am diabetic, and I think my sugar shot up to 214, 15. But I kept an insulin injection with me, but I didn't need it. Every morning it would come back to normal. So that was something that I just wanted to share.
And I'm glad you made a full recovery. And but you've gone through what is an expected kind of a routine with the COVID. And steroids will be very helpful in the situation that you've just described.
Another client of mine who was infected much later than me is 82, and he had an identical situation, and he's now out of it, and tomorrow he's returning back, to normal life. His 15 days are also very good. So I was just wondering, if you are double vaccinated and you have comorbidities, like I have a heart problem, hypertension, blood pressure, sugar, diabetes. Still, it didn't sort of hit me that hard, but maybe I was lucky. I'm just saying that. I'm just going back to Aban's question, that all of us are vaccinated, double vaccinated, and we go strongly by advice of Dr. Soniji here. And we are all been trying to avoid meetings. But as you said, how long? When do we return to normal life? We are going to office, we are going to meet people, but that's something we have to consider. So as you said, if we maintain distance and we keep our masks, I think that's the best remedy that we can have.
Very true. Very true.
How are you going to keep 3 meters distance? I can't imagine in a Rotary meeting 3 meters distance.
Not
Meeting and
3
drinking.
meters, nahi to 2 meter, 2 nahi to 1. Question is that you can have meetings outside also.
We'll have to have it in the open where there is no AC. That'd be much better.
Yeah, you can have it in the open in the initial stage, and then you can go.
Yes, why not?
But you'll be surprised today, you cannot get a single booking at the club.
Good.
There is no booking available for any banquet room today. It's all full.
That is the issue
You
with
try
all the
your level
restaurants
best,
also.
There is our safety.
But in fellowship time, you can't maintain any social distance.
Sorry, I think doctor is still here. Let's hear him out.
Yes.
I'm enjoying the conversation.
I'm sorry, we lapsed into our own story, doctor.
a burning issue now, what to do.
Any
Doctor,
more
so this,
questions?
doctor,
Sorry.
this airborne situation came out of a mutant?
No, no.
Was it originally airborne or it muted into that?
No, it wasn't originally airborne. It was still contained. Yes, there would have been a small role of a mutation. Yes, maybe even a bigger role. I can't say right now. The particle size apparently still remains the same. The particle matter is something that has changed for the worse. So I would have to say yes. I think. See, remember one thing. Uh, the virus also needs to preserve itself. Okay, it's not in the interest of the virus to disappear. So it will find its own ways of making sure that it will preserve itself. There are those viruses that will live in your cell, in your body, and they will come out in the open only when your immunity has fallen below about 30%. All right. So the problem is not that your patient has high blood pressure or diabetes or renal failure or liver failure. All of these are conditions where your immune system is weak. But the problem is it's an uncontrolled situation. If your blood pressure is soaring, if you're not responding to the medications you're taking, if your diabetes is uncontrolled, if it is under control, it should not cause you problems. It's only when it is uncontrolled metabolic conditions that will cause you problems. I wonder if that answers your question.
No, I was more interested in at what stage the mutants became airborne.
That's difficult to pinpoint. It varied from country to country, but probably after the first year of the virus living in a country is when the viruses became airborne. That's more like an educated guess on my part, not just my part, on other people's part as well. Who, when we talk amongst ourselves within the infectious disease community, that's more an educated guess. I don't know if there's any scientific evidence to that. But that's a well accepted kind of a feeling that probably after the first year it became airborne.
So would it be right to say that it is here forever to stay? We have to learn to live with it.
Well, I certainly hope not. I think it will. Do remember also, let me share with you something else, that viruses were there before us. Okay. And in fact, every other infection has come out of a virus that has changed its basic nature. Okay, that's something that we have done. We are aware of that. So whether the virus stays in its own form or mutates into something else, goes into a transformation, we don't know. We don't know. Whether it's going to become more harmful, more grievous, that also we don't know. But if you were to look at the oldest organisms on the planet, I think viruses were here something like 60 million years before the first person stepped on the planet. So I would have to say, is the virus going to be around even after we've disappeared from the scene? I think that's a fairly good chance. Yes, that's.
All right. Any more questions?
Yeah, there must be.
Thank you very much, doctor. Any other questions? Any more?
Thank you.
Thank you, sir.
Thank you, Dr. Soniji, one more time for giving.
Dr. Om, please hold on.
Thank you for coming, sir.
Sir, please hold on. I'd like to hand it over to Rotarian Madhu Gupta for the vote of thanks.
The secretarial announcements, we always forget.
Okay, I'm sorry, Mr. Lalit. Please go ahead.
Okay, coming to the secretarial announcements, attendance today is 26 members, and we had 4 guests, one from Hyderabad. Welcome to Bombay Seacoast. Hope you enjoyed this educated session on COVID. Celebrations and felicitations between 6th August and 26th meeting today. Rotarian Ajay Nagpal celebrated his birthday on the 12th August. Shailesh Mehta celebrated his birthday on the 13th of August. Our President-elect Rajiv Tikka celebrated his birthday on 20th August. And Kavita Shah celebrated her birthday on 22nd August. And on the 24th of August, Mr. Jahangir Modawala celebrated his birthday. A very happy birthday to all of you. I would like to just update all the members on the projects we did in the last few weeks, 2 weeks. We had a breast milk machines and the kangaroo bags project, which was completed. Many members joined, and we would like to have more members coming for these events when we have these live events. This event was held at the KEM Hospital, and Rotarian Kunal Kapadia, Director Medical, took the lead under the guidance of Dr. Sonaji and Jyoti. The final announcement is the next meeting, which will be held on the 2nd of September. The speaker for that meeting will be Mr. Anuj Puri. He is a real estate guru, JLL founder, chairman, and now he has his own company, Anrock. This meeting will be an interactive session on residential real estate in Mumbai and the impact of COVID on this industry. If you're speculating, will this go up or go down? It's your time to come and be part of this meeting. Thank you. Yes, Kunal. Madhuji, you can please propose the vote of thanks.
Madhuji, you're on mute.
Good evening, friends and Rotarians. Let me thank President Sudhir and Dr. Soneji for inviting this wonderful, wonderful doctor to enlighten us about COVID, its history, its past, its present, and its future, and what it holds for us. And he has given us a plethora of information, but has left us with a lot of information to ingest and to think about how we should proceed in the future months. We are very, very thankful to you for that, Dr. Srivastava. And I think the take home, in my opinion, is still that COVID appropriate behavior is the key to survival. Thank you very much.
Thank you everybody once again for a patient hearing. I'm leaving the meeting now.
Thank you.
Thank you on my behalf. Go.
Thank you, sir.
Home.
Thank you,
Thank
sir.
We'll all leave. Chalo. जाएंगे ना Sudhir is on mute.
Sudhirji, you're on mute.
The meeting is adjourned. Thank you very much, everybody.
Thank you.
Thank you.
Thank you. Good night, everybody.
Good night, everybody.
Thank you. Thank you.
Thank you.
Thank you.
Last में जाएंगे.
Who is this Galaxy A50? I can't see.
In some cases, only the device comes, in numbering. Yeah, you can't make out who it is.
So we had 27 members attending today,
Yeah.
which is a good number.
Yeah, very good.
Yeah, considering
Benefits and everybody, whoever wants
considering
to.
it's a very critical situation for everybody, I think it was a good meeting, very well attended, and the
Yeah,
and the
speaker was-
doctor is so knowledgeable, so knowledgeable.
Yeah, so calm, composed.
Yeah.
and
Okay,
step
then.
by
Thank you very
step,
much.
step by
Good night,
step.
everybody.
Thank you, Lalit.
Oh,
Thank you
Jayanti
very
is
much.
there. Hello, Jayanti. कैसे हो, Jayanti?
Good evening.
You are here or you're in Lonavala? कहाँ है आप लोग?
Very much in Mumbai.
अच्छा, अभी गए